I have a conflict of interest, and I'll point this out because I'm going to be talking about some of our data that relate to this. So knowing volume status is obviously key in critical care. We just heard a very nice presentation about a surrogate measure of volume status. And every heart organization, every critical care, every nephrology organization recommends being able to understand volume status, and yet measuring intravascular volume status has eluded us till even today, and it's time to start thinking about how we can do that, because I'm convinced that we can help our patients tremendously. So the paradigm I'll speak about a little bit today is just very simply left heart failure. It's something you know extremely well, and this is just a cartoon putting together the different pieces. I think we always have to remember that everything that comes in with edema is not left heart failure, and I'll touch on that briefly as we go along. But my charge in this session is to talk about the pharmacologic management, and therefore I'm going to spend most of the time on diuretics as we go through it. So obviously the goal of volume assessment is to have optimal fluid balance, which is an individual patient type phenomenon. You suffer from volume depletion in some of our patients, you suffer from volume overload in many of our patients, and the physician is responsible for changing one to the other by not understanding and being able to quantify adequate volume status in our patients. So this is a cartoon looking at the overall approach to volume overload. You know this probably better than I do because many of you live in this environment daily. And it breaks down into the decompensated congestive heart failure patient or the CKD patient who comes in, who's already on multiple diuretics. He's on an ACE inhibitor, aldosterone antagonist, etc., and presents with increased total systemic volume heart failure exacerbation. If they are perfusing well, it's a fairly straightforward approach. The patient's handled on the wards, and one can start avoiding ionotropes and start with intravenous diuretics. You must again educate your patient. We deal with nephrology patients who seemingly need educated about once a month. It's a flexible diuretic regime. There's no magic bullet, no magic protocol to go down. We'll talk about some of this. And if that does not work well, then one considers the vasodilators, both venous, arterial venous, and finally ultrafiltration, which the next speaker will talk about. You end up with a stable patient, they can go home, and that's the vast majority of our outcomes in our patients that present with decompensated heart failure. Often we have recurrent hospitalizations, and in our country, you now pay for those out of hospital funds. And it's becoming a biomarker of how good the physician is by limiting rehospitalization. And finally, there are those patients that worsen, develop a cardiorenal syndrome, and they flow over then to the side of the cartoon that is hypoperfusing, and that's hyperperfusing the entire body. And in those patients, one then has to consider ionotropic support. Dobutamine and milorone are the obvious two choices that people debate. We primarily use dobutamine. You again then start over with your intravenous diuretics, and if you're lucky, you get to taper those down, you get to get rid of the ionotropic support, and you move forward. Sometimes a mechanical assist device is necessary, that's rare, and sometimes palliative care is involved in an end-stage disease patient. Many of our cardiologists now are using ionotropic support for end-stage patients and then sending them to a hospice with the dobutamine in their pocket to use in the hospice until they become refractory and then pass away. I personally disagree with this approach, but that's the approach that's being taken. So let's look at the approach to diuretics in these fluid overload states. And obviously, we start with the loop diuretics. You use these daily. IV, PO, depends upon the status of the individual patient, whether you're going to give the IV in a bolus or a continuous fashion, again, depends upon the individual patient, whether they're on the ward, whether they're in the unit. If you want more hourly to hourly control, I like the continuous. You're going to need to consider combination diuretics, and we'll spend a couple of minutes on why that's true. The thiazides are obviously the starting diuretic in those cases, and many people add to it a K-sparing diuretic for a number of reasons in the cardiologic world. Antifibrotics is top of the list. Acetazolamide can be considered for those patients that have a high bicarb to be used, again, in conjunction with loop diuretics. We'll touch a little bit about albumin administration, but if I were to sum up the field, I would say that it's only been shown in prospective studies to work for cirrhosis patients that have a low albumin to start with. We're not going to talk about right ventricular failure because there's been very little progress in this field, although there are a number of potential therapies that are being tried now. This is a confounding pathophysiologic phenomenon. It is not diagnosed nearly enough. Our cardiologists are just beginning to learn that there is a right ventricle. Our pulmonary critical care team has known that for many, many years. And you all know that if you have right ventricular failure, that these are the most difficult patients to try and diurese. I would also point out that we get called weekly for late-stage CKD patients and ESRD patients by the ER and by the ICU, telling us to come in, and we must absolutely emergently dialyze our patient who comes in maybe 1 or 2 kilos up, was dialyzed appropriately the day before, and is now in florid pulmonary edema. The only thing you have to ask is what's the patient's blood pressure, and it always comes back to be 200 over 110 to 120, and you tell the physician if they would just control the blood pressure with nitroprusside or however, that the volume will redistribute, and we don't need to come in and dialyze the patient. Now, sometimes this works, often it doesn't. We go in, we control the blood pressure, the fluid redistributes, and we don't have to do emergent dialysis in the middle of the night. But this is very common to a nephrologist if you're out there sitting in the crowd. So let's look at the use of diuretics, and let's look at where they work. And this was a cartoon that I took from Nature Reviews Cardiology. And one can see that the proximal tubule, acetazolamide, works there. Some people will tell you that thiazides do have a bit of ability to increase sodium loss by the proximal tubule, primarily from inhibiting, again, carbonic anhydrase. Mannitol is listed, but I don't think anyone here uses mannitol. We certainly don't use mannitol because of the potential for osmotic overload. You have the loop diuretics, which we all know inhibit the sodium-potassium chloride cotransporter and are the most effective diuretics we have. And we have the thiazide diuretics, which in and of themselves are relatively mild diuretics. However, when we use loop diuretics and flood the distal tubule with sodium, the thiazide diuretics then become much more potent in their ability to induce a diuresis. It's shown a number of years ago by David Ellison in some elegant preclinical studies that with use of loop diuretics, there's hypertrophy and increased sodium channels and sodium-potassium ATPase in the distal tubule, such that the inability of your loop diuretics to work is due to overriding sodium reabsorption distally. So, and finally then we get to the aldosterone antagonists. We all know that they're potassium sparing, they increase sodium excretion, and not listed in this cartoon is amiloride, which is also a very effective sodium channel blocker, K sparing, and is not dependent upon aldosterone. So there was a study by the next speaker a few years ago looking at whether continuous versus bolus furosemide was best in these types of patients. And bottom line of this small ICU study that was well controlled and well done is that in the bold print there in results, bolus group required significant higher dose of furosemide needed to achieve target diuresis, 24 versus 9 milligrams per hour of infusion, but the overall diuresis was the same, the overall hospital outcome was the same, the change in serum creatinine and the change in eGFR were all the same based on whichever you gave bolus or continuous. So from this, we can learn that if you want to prevent ototoxicity with high doses of furosemide, that using continuous is probably a very reasonable way to go. I like it in the ICU patients in particular, the more severe ones, simply because I think it gives me a little bit more hour-to-hour regulation over their urine output without peaks and valleys throughout the day. Intravenous doses of diuretics, the point I want to make here to the fellows, and I think they probably already know this, is that the dose of the diuretic, loading dose and continuous dose, is dependent upon the GFR. Obviously, the better the GFR you have, the lower the dose you need to get the same response. And this just gives you a ballpark on where to start with your patients based on what you think the GFR is in those patients. So resistance, people talk about 3 different types of resistance. I think there's really just rebound sodium reabsorption as the primary type of resistance. This starts at the glomerulus because you have sympathetic overdrive, you have vasoconstriction, and so automatically your GFR goes down. And I just told you, if you have a lower GFR, you need higher doses of your diuretic. So it starts with glomerular filtration. It then extends to the proximal tubule, where your high A2 levels increase sodium reabsorption and block your natriuretic effect within it. And even a low flow in the proximal tubule leads to a higher sodium reabsorption independent of anything else going on in the proximal tubule. We've talked about the distal tubule briefly already, and that is the hypertrophy of sodium-potassium ATPase and the sodium channel, subsequent with increased sodium reabsorption there. I found this cartoon was wrong in that case, so I had to insert the increased rather than the reduced. And then in the collecting duct, aldosterone increases sodium reabsorption, which can be overcome with the aldosterone antagonists. So this is why you need multiple diuretics, starting with the loop, going to a thiazide, and subsequently with an aldosterone inhibitor. But at this point in time, you also have to think about other things, and you should really think about these when the patient comes in. Every patient that comes in volume overloaded is not in worse congestive heart failure or worse chronic kidney disease, especially our patients who have severe CKD. You have to talk to them about their sodium intake. You have to talk to them whether they're taking their medications. I'm sure noncompliance is the biggest problem here, as it is with our patients. You have to see if they're taking nonsteroidals for the twisted ankle that they developed over the weekend. You have to worry about further decreases in their GFR and such that it's really not noncompliance, but they need higher doses to achieve the same level of sodium loss. And finally, you have to think about other things going on in the heart that just worsening congestive heart failure, but acute events that could lead to the subsequent lack of diuretic response. I throw in one study that was done 10 years ago where they looked at a randomized controlled trial of furosemide with or without albumin, because this is a common question in hypoalbuminemic patients. Should we be giving them albumin? I mentioned before that the data only support use in cirrhosis patients. And this was looking at hypoalbuminemic patients with acute lung injury. And if you look over at the p-values, you can see really that the only thing that changed was there was, with albumin, again in hypoalbuminemic patients, a greater net loss of fluid over 3 days. There was an increase in serum albumin, which one would expect, and there was an increase in the rate of furosemide infusion, being less in the albumin-treated patients. But as far as ventilator-free days, as far as hospital stay, as far as ICU mortality, there was no difference. Now, this was, again, a small study. The reviews of this indicate that we do need larger studies before any kind of meta-analysis can be done and drive whether or not we should be using albumin in hypoalbuminic patients for this type of phenomenon. So what about inotropes? In this particular patient population, the left ventricular dysfunction patients and the CKD patients, obviously digoxin is an age-old inotrope that's fine for outpatient, but it's not something you're thinking about giving necessarily in hospitalized patients. Dobutamine is our first choice. It's a beta agonist. It works by increasing cyclic AMP and therefore calcium entry and stimulating myocardial contraction strength or inotropic. It is used obviously in shock, palliative use in end-stage disease when you have to drive the heart to get rid of the fluid. And often patients will then go into a vacation type period where they can go home for a month on the same dose of diuretics that they came in on, and they will do fine until something tips them over. No real effect on mortality with use of dobutamine, and pretty much the same is true for millerone, although I have much better handle on using dobutamine in these patients. Dopamine, probably not, and then a lot of other compounds which are under investigation. I have to tell you that I'm a little bit jealous of the veterinarian world. My daughter is a veterinarian, and we were talking about congestive heart failures in dogs, and she starts with Lasix, and then she goes to a calcium channel agonist. And I said, what is it? She told me what it was, and then she told me, well, yeah, Dad, it was made for people, but it was too toxic, but it works great in dogs. So they have drugs that we don't, work in different mechanisms. I put at the bottom of this slide relaxin. It's not an inotrope, it's a vasodilator. It's a relatively new drug. It's a natural occurring human peptide. There's one large 1,100 patient study out there looking at it, and over time, not during the hospital stay, but over 6 months, there was a reduced all-cause and cardiovascular mortality using this, but obviously it's still investigational, has a way to go. Now, what I really want to spend my next few minutes on is not the therapeutic approach to volume overload. I think you understand that. And we have great agents, but we can't evaluate intravascular volume. We have surrogates of intravascular volume. It's not difficult to pick out the congested patient when they walk into the ER. What's difficult is when they've been in the hospital a few days and you get called to do a renal consult because the creatinine's going up because the patient got the IV diuretics, and then they got fluids, and then they got IV diuretics, and they want you to come solve the problem. And you try and go do an evaluation to see what the volume status is of that patient, realizing that intravascular volume relates to, but is not congruent with, total body volume. And have you dried the intravasculature out, even though they still have tremendous elevated interstitial fluid? So bottom line here is that we should monitor primary parameters of our therapies are changing. So antihypertensives and vasopressors, we monitor blood pressure. Inotropes, we monitor cardiac output. Isoproterenol, atropine, and pacing wires, we monitor heart rate. Packed red cells, we monitor hematocrit, hemoglobin concentration. And for IV fluids, we should monitor IV volume. That's what counts. That's what allows the heart to create effective arterial volume. So let's look at this. And I know this takes you back to first year medical school. I apologize somewhat for that. But the point of this slide to me is if you look on your left, you see the total intravascular volume is 5 liters. 3 of that is plasma, 2 of that is cells. So you're dealing with a very small volume that you are trying to extract a lot of volume through, okay? I was amazed when Ronaldo was saying they were taking off 400 mils an hour with CVVH. I've never attempted anything close to that. I would be frightened to death to do that. So just because the patient has massive interstitial volume, you don't know how quickly they can mobilize it, and you want to be careful that you don't volume deplete them and make your renal problems worse. So, commonly used clinical laboratories, I think I can skip these. These were mentioned by the previous speaker. They're very important. You have to develop your clinical acumen. I think critical care docs and nephrologists are the best at evaluating volume. I think cardiologists used to be very, very good at it, but they have so many toys now that help them so much that they've kind of forgot about evaluating volume. One has to look at volume assessment tools. So history, physical, chest radiograph were discussed previously. Central venous pressure, I'll show you one slide to show you that it can work in some patients, but it can fool you in many, many other patients. Pulmonary capillary wedge, invasive, it's a static, and it's got poor correlation with fluid responsiveness. And remember, fluid responsiveness does not mean volume deficit. I can give any one of you who have normal kidney function in here and normal volume a liter of saline, and I'll guarantee you your cardiac output will go up, your blood pressure will go up, and your GFR will go up, and your fluid responsive. Doesn't mean your volume depleted. Okay. Stroke volume, pulse pressure variations, esophageal Dopplers, vena cava diameter. These are all surrogate markers of intravascular volume. This is just looking at CVP in a large number of patients, looking at the deficit or excess of blood volume in those patients when it was measured, and you can see how wonderful a tool it is. You already know that. So what do we have to measure plasma and total body volume? Well, in Europe, you have the chromium-labeled red cells. We don't have those in the United States. We have iodine-labeled albumin. We have the Daxor, which is basically a commercialized iodine-labeled albumin. We have Evans Blue no longer. And we have ICG that is, I think, less accurate than the Daxor, the labeled albumin. And all of these work on a dilution principle. You can see in the lower left-hand corner there, volume times concentration equals volume times concentration. So if you inject a known volume with a known concentration, you can then subsequently measure the concentration in the plasma, and you know how much has been diluted. The other thing that I will point out to you, and we haven't started to tackle this that I know of yet, and that we talk about plasma volume, we talk about blood volume, but what's more important? Plasma volume, blood volume? Obviously, blood determines a tremendous amount of your total intravascular volume, and we haven't really broken down how to think about this. So I'm going to speak just a little bit where I'm conflicted, and I'll point that out again, but there are two direct measurement tools right now. There's the Daxor that's commercially available. You can see there it's a bolus injection of radioactive albumin. They then take 5 samples and extrapolate back to 0 time point. It's based on dilution. It measures both blood volume, plasma volume, and you have to have the hematocrit, and it's a direct measure. We've come up with a very similar technique. Instead of using radioactive albumin, we use a very large fluorescent dextran, take a blood sample and measure the fluorescence in the blood sample. So again, the dilution technique. This is just a cartoon of that. In my next talk, a little bit later, I'll talk about the GFR aspects, but this is the volume aspects. And so our plasma volume marker is a rhodamine, so fluorescent tagged, 150 kD dextran. 150 kD was selected so that it potentially would be less likely to leak even in sepsis patients out of the vasculature. In normals and in CKD patients, it does not leak. It has a half-life of 72 hours, and it remains constant after injection for, we know of, up to 6 hours. We've done one phase 1 study in Germany in normal patients. We could only compare our measured plasma volume to an estimated plasma volume, but you can see on the right-hand side there that it compares very favorably. There were no side effects or whatever. We actually inject only 50 milligrams of dextran for this test. I want you to concentrate on the blue line here, and that's the stability of the large dextran that we've seen in, again, normals and in CKD patients over time. And so this allows us to do something that's very interesting, and that is we can now start to talk about dynamic volume status in guiding fluid management. So this is a study we've done in dogs. We have not done this in humans yet, where we had a dog that was fasting, several dogs that were fasting, and we injected 350 mils intravenously into them over 9 minutes. and we measured serial samples to see what their plasma volume did. And you can see there it starts at a little over 1,000, it goes up to 1,250, and then as the saline moves out into the interstitium, comes down and settles at an equilibrium point. So we have increased their volume with this 350 mils. Now we think this can be used both in looking at giving volume to patients that are septic and you think their volume status, or you've quantified their volume status to be low, and seeing how long it hangs around, or it can be used in your patients you're giving diuretics to see how rapidly they can mobilize fluid and what you're doing to their volume status. Does this make a difference? Well, this is a study done with the Daxor machine where they looked at 43 consecutive ambulatory non-edematous patients with CHF. They had clinical assessment and they measured blood volume, and they were concordant in only 51% of the patients. Okay, so the physical exam, the history was wrong nearly in a majority of the patients. This is just looking at the excess and deficit plasma volume in that study, but again, the physicians were wrong with whether or not they thought volume status was up. Another paper, this time by Yu in Shock a little more recently, where they looked at resuscitation with both blood volume management and without blood volume, knowing the blood volume. There are their goals, resuscitation, fairly straightforward goals. And this is what they found, and that is in the patient that had blood volume measurements, they could see a decrease in mortality and a decrease in their mortality and their score. So the results of that showed blood volume analysis resulted in a change in treatment of 44% of the time compared to the control group, and significantly reduced mortality when it was used in patients for study. So I'm just going to leave you with fluid overload is obviously a very important clinical problem. There's different levels of urgency to treat it. Diuretic resistance certainly does occur, but it can be overcome in the vast majority of patients. We'll hear about those patients where it can't in the next speaker. Combination diuretic therapy is effective, but has major clinical complications, as we all know, especially if you're a nephrologist and you get called when the creatinine goes up and internists are throwing their hands up. The underlying pathophysiology is critical to understand when we're dealing with volume overloaded patients. It's not all left ventricular failure. Being able to quantify plasma and blood volume would allow careful titration of therapy and being able to follow it in a dynamic fashion. And a dynamic understanding of volume therapy would minimize complications and likely shorten hospital stays. Thank you very much.